here. We have two really great aortic articles that we're going to talk about this evening from this month's JVS. The first article we'll cover is a more proximal landing zone is preferred for thoracic endovascular repair for acute type B aortic dissections. And we have authors from that paper here to join us and discuss it. We're very excited about that. And the second article we'll cover is the natural history of large abdominal aortic aneurysms in patients without timely repair. And Dr. Lancaster, who is a general surgery resident at UCSF, will be joining us to discuss that along with Dr. Chang. Our host institutions this evening from the University of Michigan, we're thrilled to have Dr. Dawn Coleman, who is the Associate Professor of Surgery and Program Director for their Integrated and Fellowship Program. And the fifth-year integrated resident from Michigan, Dr. Christopher Adu. They will be going over our TEVAR article. From Dartmouth, Dr. Jesse Colombo, who is an Assistant Professor of Surgery, and Dr. Aaron Barnes, who is their sixth-year integrated vascular resident, will be discussing the large aneurysm article. Our author guests this evening from the aortic dissection article are Dr. Gene Panton, and he is a professor in surgery, division chief of vascular surgery at Eastern Virginia Medical Center, or Medical School, and also Dr. Anamish Rathore, sorry. And we're very excited to have everybody here. It's great when we have the authors join because it really stimulates great conversation. Dr. Robert Chang is the Assistant Chair of Vascular Surgery at Permanente Medicine in the Bay Area of California. And Dr. Elizabeth Lancaster, as I mentioned, is a general surgery resident who was the first author on the large aneurysm paper. To moderate and bring up pertinent points to the paper itself and to help us stimulate great conversation, we have two guest moderators. Dr. Matt Eagleton is the professor and chief the Division of Vascular and Endovascular Surgery, and he is the director of the Fireman Vascular Center at Massachusetts General Hospital. And then Dr. Young Erden is associate professor of surgery at Mayo Jacksonville. We just want to go over a couple of housekeeping items this evening. Please stay muted. The moderators may call on you to unmute and ask your question, but we do ask that you put your questions in the chat so that they can be addressed. The event is being recorded, as you just heard, for on-demand access. And then, of course, we have our February JVS Journal Club, which is coming up on Wednesday, February 9th. It'll be at 6 p.m. Eastern Time. And that's going to be hosted by the NYU Grossman School of Medicine, Dr. Karan Rachman, and also by Penn State University, Dr. Tanya Floor. We are finalizing the dates for April through August now. If you signed up for one of those dates, you'll expect to get an email. And if you haven't signed up or haven't gotten the link to sign up, please let us know and we'll be happy to send that to you if you're interested in hosting. So from here, I'll stop sharing my screen and we can turn this over to Dr. Coleman to kick us off.
Thank you, Dr. Humphreys, and welcome everybody. It's so exciting that the University of Michigan can participate in this evening's event, so thanks so much for this opportunity. I am pinch hitting tonight for Dr. John Eliason, who extends his regrets for not being able to kind of moderate this particular manuscript alongside Dr. Odu, and I'll do my best to represent on his behalf. And I just want to give my gratitude to both Dr. Odu, who'll be speaking shortly, and Drew Brait, two of our phenomenal integrated residents who've put a lot of time and thought into this presentation. And so with that, I'll just share on behalf of all of us. We have no disclosures that are relevant. And I'll ask Chris to move forward to the next slide. Perfect, thank you. All right, so I don't think that there needs to be much explanation to this audience about aortic dissections, but just for brief overview, this is a potentially lethal acute aortic syndrome. Essentially, a dissection is a tear in the intimal layer of the arterial wall that does not affect the adventitia, creating a true and a false lumen. And when this happens in the aorta, we get a dissection. And these are further classified essentially by anatomic location, depending on where the intimal tear occurs. which you can see on screen right. Specifically, a type B dissection is defined by an intimal tear distal to the left subclavian artery that spares the ascending aorta and arch, and this is the pathology to which we'll speak today. There are many risk factors for type B aortic dissection, and the most salient to this audience perhaps would be that of uncontrolled hypertension, but we also appreciate the etiologies that follow connective tissue disorders, vascular inflammation, deceleration, trauma, and there are a multitude of other iatrogenic factors that can come into play. Let's see. Oh, different slides, Christopher. We classify dissections in part based on their chronicity and then their complication profile or disease severity, essentially. And screen left shows the SVS-STS classification scheme that qualifies hyperacute dissections as being less than 24 hours in duration, acute being 1 to 14 days duration, subacute 15 days to 3 months, and chronic being over 3 months. I think that's extremely relevant when we talked about optimal timing for treatments. And then dissection severity is further qualified by those that are uncomplicated, specifically no episodes of rupture, malperfusion, or other high-risk features. The high-risk features are shared in this table, which you all can read. And the feared complications that increase morbidity and mortality include rupture and malperfusion. All right, so the mainstay of treatment, rather, I guess I should start the initial management of acute dissections is that of pain control and anti-impulse therapy, essentially controlling the blood pressure and reducing ventricular ejectile forces will reduce the propagation of dissection. Blood pressure goals are reduced to the level just enough for end organ perfusion, and IV beta blockade is probably the most important agent to consider. And while medical therapy has been the mainstay of treatment for uncomplicated type B dissections, TEVAR has dramatically changed the landscape of care for patients with this pathology, offering a much lower risk of morbidity and mortality than open surgical management ever has been able to do. And this offers additionally the opportunity for false lumen thrombosis and may decrease the risk of further aneurysmal degeneration. And some of this is based on the early INSTEAD trial, which was the first study of 140 survivors with stable type B dissection to suggest that TEVAR, in addition to optimal medical management, is associated with improved 5-year aorta-specific survival and delayed decreased progression. And in stable type B dissection with suitable anatomy, preemptive TEVAR has been considered now the standard of care to improve late outcomes. With that said, there are questions remaining regarding the optimal timing of TEVAR for dissection and, importantly, the optimal site for proximal seal. And in general, we favor a 2-centimeter segment of healthy aorta for proximal endograft landing. In type B aortic dissections, however, the proximity of this primary entry tear to the origin of the left subclavian artery or a retrograde extension of the false lumen or intramural hematoma can make this difficult to achieve without coverage of one or more of the aortic branch vessels, which would necessitate perhaps an additional procedure. And additionally, there's a reported risk of rupture in some series, with proximal being zone 1 or 2 seal. This rate is about 2.5%. And finally, extended proximal coverage may be associated with increased risk of stroke and spinal cord ischemia based on some data. And so with that, our authors tonight with us, next slide, have looked toward a more proximal landing zone as preferred for thoracic endovascular repair of acute type B aortic dissections. And with that, Dr. Odu will take over.
Very well. Thank you, Dr. Coleman. And thank you for the kind introduction earlier. So this paper really is trying to answer the question. And I think the best way to see it is through their own study objectives, which was to evaluate and compare postoperative outcomes and the late aortic related adverse events in patients who undergo TEVAR, depending on where the proximal endograft was deployed, either zone 2 or 3. So moving forward, the methodology for this study is that it's a single institution retrospective chart review, and including all adult patients who underwent TEVAR for acute type B aorta dissection within 6 weeks of diagnosis, and it spanned over a 10-year period. There were some exclusion criteria here, though. So patients who had come in with known connective tissue disorder were excluded, as well as those who had had a prior type A repair. Those patients were then, that went forward, were then stratified into those who received zone 2 TEVAR and also those who received zone 3 TEVAR. And the zone 2 folks were further stratified into those who received revascularization and those who did not, as designated there. And revascularization being defined by bypass or left subclavian to carotid transposition, or in situ laser fenestration with a stent. There are a couple things for comparison for this study. So they compared need for aortic reintervention within a 36-month period, as well as freedom from aortic-related adverse events, or AREM. And I've listed the particular adverse events that they studied underneath there. Just a couple things to mention here that all patients had either undergone immediate TEVAR due to impending rupture as determined radiographically or symptomatically, or they were admitted to the ICU and then progressed to TEVAR if clinically indicated. And typically that meant on expansion of the aorta on repeat imaging. Finally, the proximal endograft zone, landing zone, was left to the attending surgeon based on some of the considerations that had been mentioned earlier. So the numbers for this study was that total number of patients was 83, and those who were stratified who had a zone 2 procedure were 48, and those with zone 3 was 35. And as you can see, zone 2 were further stratified into revas 38, and those that weren't into 10. So starting off with the study demographics, it's important to know that the two major groups were well matched demographically. And particularly with this data, what was significant was that the zone 2 patients had shorter distances from the left subclavian artery to their entry tear. And they had shorter length of non-diseased aorta from the left subclavian artery here. And that was found to be significant. Indications for TEVAR are as listed here. Significantly, most of the patients that were treated with zone 2 proximal landing had a visceral malperfusion, and that was significant. And then more patients with uncontrolled hypertension, however, were treated with zone 3 proximal landing. So they did look also at adjunctive procedures that were performed, and I just highlight here some of the notable things that was noted in this study. In this cohort, the patients treated with zone 2 proximal landing had higher number of adjunct interventions performed, including renal artery stenting, aortoiliac percutaneous fenestration, as well as any other adjunct interventions for malperfusion. So it seems like this group came in and presented sicker than those who underwent zone 3. So the meat of the study, however, is when we look at the postoperative outcomes and the late aortic-related adverse events. So to focus on the postoperative outcomes, they looked at these particular factors here, and significantly was noted that those who underwent zone 2 proximal landing had longer operative time and also had longer length of covered healthy aorta. I will mention that although it's not parsed out in this table, the authors did report that the rate of permanent stroke was 4.8% and was similar between all the groups. And also the postoperative spinal cord ischemia was significantly higher for those patients that did not get revascularization, coming out at about 20%, compared to those that did get zone 2 revascularization, coming out at about 2.6%, and 0% for those that underwent a zone 3 proximal landing. And that was actually significant, reported in the paper. So when we look at the freedom from aortic reinterventions, those who underwent zone 2 proximal landing had a higher and more significant freedom from reintervention later on, and that was true out to 36 months. And equally, when you looked at freedom from adverse aortic-related events, that was also true that those who underwent zone 2 landing had a significant improvement or freedom from morbidity and mortality related to their aorta. So these two figures are kind of the meat, if you will, of the paper, and just wanted to highlight this. So to summarize then, Zone 2 proximal TEVAR landing seems to avail patients from freedom from aortic reintervention and morbidity mortality due to the aorta over 36 months. The length of proximal healthy aorta was longer in those who had a Zone 2 landing versus those who had a Zone 3 landing. And also the postoperative spinal cord ischemia rate was higher for those who did not receive a revascularization compared to those who did amongst the Zone 2 landed patients. And then finally, those who had underwent Zone 2 proximal landing had no higher incidence of carotid complications associated with that or the associated interventions that was reported. So that's the kind of the crux of the paper. I will stop here and open it up for further discussion.
Thanks. Congratulations, Dr. Adu, on a great presentation summary of the manuscript. Please put your questions into the chat so we can ask them for the authors. I find this a great paper. There's a lot of data here. There's a lot of experience here. And I learned an awful lot from this paper. I have some questions for Dr. Rathore and for Dr. Panaton as people are putting their presentation and their questions into the chat box. I'm interested in why type 3 repairs or zone 3 repairs have a proclivity to develop a complication, but the length of healthy aorta cover doesn't. I think you show that in the analysis. And why is that? Is it just the anatomic location in zone 3 where we ultimately causing an injury to the aorta in that location because of a poor seating of a stent graft, or is there something else going on?
So first of all, thank you for the opportunity, and I hope you can hear me. Okay, so thank you for the opportunity to discuss this paper. I think the major thing that we see in acute complicated type B dissection is really the fact that there's a lot more diseased aorta proximal to the primary entry tear. And I would say a common mistake that we tend to do is to just try to do a zone 3 TEVAR because it's so much faster and easier. You don't have to deal with the left subclavian artery. But a lot of patients that had those zone 3 TEVAR ended up requiring a proximal reintervention. And the reason for those proximal reinterventions were either an RTAD, retrograde type A, or a type 1A endoleak, meaning that basically that TEVAR was done in a zone of thoracic aorta that was already sort of compromised either by some element of retrograde dissection or some IMH, because we see a lot of IMH that goes proximal to the primary entry tear. So I think we're definitely, as an institution, moving toward a more aggressive stand to do more zone 2 TEVAR. Obviously, it does require a little bit more work because you do have to, and we're very aggressive at making sure we revascularize the left subclavian artery, because this paper also showed that in an acute dissection, if you do long coverage and you don't revascularize the LSA, you really risk having an increased spinal cord ischemic injury rate. So I think I would say that's what we've learned from this experience.
I'd point out, Dr. Panaton, you don't undersell it. I mean, not just a slight increase in spinal cord ischemia rates, there's almost an 8-fold increase in the risk of spinal ischemia without subclavian revascularization. That's pretty impressive. So does your group now predominantly try to cover the left subclavian and revascularize it for every dissection?
I mean, personally, I would never sacrifice a left subclavian artery in an acute or a chronic type B dissection. It's a major vessel. Maybe in some traumatic transection, we occasionally cover it because it's a very short TEVAR. It's a very different pathology. But whenever we treat aortic dissection, we revascularize the left subclavian artery. If it's a chronic dissection, we're going to do it electively by doing a surgical debranching. But if it's an acute case, acute type B or acute IMH, the technique of in situ laser fenestration makes it so easy. It takes literally 5 minutes to revascularize the left subclavian artery. So it really is a great way to revascularize it without having to actually do a bypass.
Okay. We got some questions from the audience for you. Vic, you've got a question up there. Do you want to ask your question?
Yeah, well, thank you, Jean. Great paper, great presentation, Christopher, and congratulations. I know you're trying to compare two cohorts of patients, but my question for you is, are they really comparable? Are they different animals, different cohorts, if you will? And then the more provocative question, let's say you have 3 or 4 centimeters of what looks like healthy aorta beyond the left subclavian. Will you just bring your graft, let's say within a centimeter of the left subclavian, or as was asked by Matt, will you plan to do something more aggressive and get into zone 2? Thanks very much. Enjoyed your paper.
Yeah, thanks for your comments and great question. I think the groups are actually fairly comparable. I mean, if you look at their comorbidities, their age, and their mode of presentation, they are. In fact, if there's one thing, the zone 2 patients ended up having a lot higher incidence of visceral malperfusion than the other group. So actually, the zone 2 patients were worse than the zone 3 patients. That's the only difference that we really found when we look at when we analyzed the 2 different groups. So they are very similar. The only difference really is anatomically, is the location of the entry tear and the quality of the aorta proximal to that entry tear and the distance of that diseased aorta to the origin of the left subclavian artery. And this is really the anatomic factor that we found had the biggest impact on our decision-making process to decide let's go more proximal, and also on the I guess the severity of the aortic dissection.
Great, thanks. Tom Forbes, you have an interesting question.
Yeah, thanks, Matt. Great paper, JP. Thanks for huge experience. I just had some questions whether the group could learn maybe some technical tips from you. You know, your experienced thoracic endografter, as you go more proximal in the arch, say from zone 3 to zone 2 and more proximal, what kind of tricks do you employ? Things like maybe less oversizing or selection of endografts, which might minimize the risk of, say, bird beaking or retrograde dissections. And what do you use? What adjuncts do you use for proximal deployment? Do you use permissive hypotension? I mean, back in the day, we used to use adenosine. I don't think anybody uses adenosine anymore. But you know, what do you guys use?
So if we do a very aggressive zone 0-1, we're going to do rapid pacing for sure. For zone 2, we've not used any adjunct like adenosine or rapid pacing. We just lower the pressure as you said. I would say that in a lot of patients, especially young patients, in some ways it makes sense to go to zone 2 because they have such an acute or more Gothic arch, and if you try to be in a zone 3, this is when you end up with something that looks a lot worse. You end up with more bird beaking because you don't actually purchase that curve into the actual arch. You try to remain with the descending thoracic aorta. And this is where we've seen issues of type 1A endoleak in those zone 3 patients. So I think learning to just go around that band, and as I said, it does force you to do more work to revascularize the left ventricular artery. But the graft tends to lay a lot better in the aortic arch as a zone 2 than a zone 3 in a majority of patients. Now, obviously, ideally, using a non-bare stent also makes a lot of sense in those fragile aorta, either with IMH or acute type B dissection. Great question. Thanks, Tom.
Somewhere along the lines of the complication, I think Paul DiMuzio asked this. What was the timing of the retrograde aortic dissections that you saw? Were these occurring acutely, or are you seeing those later on in follow-up?
Well, there's a couple of patients that were excluded because they were CTD patients, like Marfan or LDS patients. So those were excluded. And those 2 RTAD that we had in those patients, they're not in that paper, those were very, very acute. They were within 3 to 4 or 5 days. And obviously, those are patients that we did not know that they were Marfan or LDS patients. But the 3 RTAD patients that we had in that paper were actually fairly late, 4 months, 16 months, and so forth. So they were late dissection. And all of them, 2 of the 3 of them were actually purely asymptomatic RTAD. They showed up in the office with their either 6 months, 12 months, or 18 months CT scan with a retrograde type A dissection that was totally asymptomatic. 2 of those 3. So those were late RTAD dissection. They still required treatment. 2 of those were treated, and one of them did not make it. This was one of the deaths, unfortunately.
Wow, that's pretty impressive. Tom Lindsay, I think you've got a question out there.
Yeah, Jean, there's a great series, and I thought the paper was well written. So in terms of the numbers of patients, obviously it's not a big series of 2s and 3s, and most of these seem to be complicated dissections. I think it was about 50% had some sort of malperfusion. But you must be seeing a lot of other dissections that are managed medically. So what sort of percentage of patients of the dissections you're seeing are you intervening on, and how many are getting medical therapy?
In that paper, those were all acute complicated dissections. So some were the severely complicated with rupture and malperfusion. That was nearly about 2/3 of the patient. The other one were patients that, despite 3, 4, 5, 6 days of intense IV, double, triple drips to control their blood pressure, 3, 4, 5 PO meds, and we still can't get a hold of the blood pressure, and we're forced to actually end up having to do a TEVAR eventually. So there were some of those, about 1/3 of those. I would say in our patient population, it's probably about 2/3 of the patients end up getting a TEVAR in their index admission, and about 1/3 of the patient, the other 1/3, we end up being able to manage medically. And I would say the younger the patient, the harder it is, it seems, to be able to control their blood pressure and to be able to avoid having to do an early TEVAR.
Well, thank you. I think that generated a lot of great discussion. And just one last question as we move on before our next article. We've had Joe Lombardi on here last year talking about one of his papers in the JVS. And he's a big proponent of using very short covered stents, a long dissection stent, and covering the subclavian with impunity. So were your stents covered, or how much of them were uncovered stents, or was all of the stent that was placed covered?
Yeah, these are all patients with regular stent graft. We were we were big enroller in the stable 2 trial. Those patients are not part of that study. I think covering the left subclavian artery with impunity, I actually do not believe that. There's so many patients that actually are highly dependent on a patent left subclavian artery, and it's so easy to keep it patent that I think there's really barely any reason in an acute dissection patient to sacrifice the LSA. The dissection stand from Cook, I think it's a niche product. I think there's patients that will need that, but it's the kind of patients that after you've done a proper TEVAR, if you still have compression of the true lumen, making sure that you've eliminated the entry tears and you still have true lumen compression, then I guess it's the kind of patient you can put a dissection bare stent across the visceral vessels to try to prop that true lumen open. In my experience, it would be less than 5 to 10% of those patients.
Thank you. Thank you very much. We're going to shift gears. We're still in the aorta tonight, though. That's our theme. And we're now going to move to our next article, and I'll ask Dr. Jesse Colombo to introduce that.
Perfect. Well, thank you. My name is Jesse Colombo, and I'm one of the faculty surgeons at Dartmouth. I'd like to thank Dr. Humphreys and Dr. DiMuzio for asking me to discuss this article tonight, and thank Dr. Stone for asking me to represent Dartmouth. Tonight we'll be talking about the natural history of large AAAs. Now, the history of large AAAs in vascular surgery has a long and storied history, as I'm sure that you're all familiar. I think an appropriate place to start is with the clinical practice guidelines from the SVS. I'm sure you're all familiar with these numbers. The SVS recommends repair of fusiform AAAs that are 5.5 centimeters or larger, and suggests repair of aneurysms that are 5 centimeters or larger in women. Well, where did the data come from that inform these guidelines? Well, much of what we know from our management comes from what we know about small AAAs. Shown here are the primary figures from the ATOM and UK small aneurysm trials, where you'll recall there was no difference in mortality between repair of AAAs smaller than 5.5 centimeters when compared to surveillance. But what about large AAAs? Well, data in this area is quite limited, primarily because large AAAs are usually repaired surgically, which is why tonight's paper by Drs. Lancaster and Shang is so important. Shown here is the primary figure from the EVAR2 trial, which demonstrates nearly twice the risk of AAA-related mortality for surveillance when compared to surgery. Smaller, retrospective observational studies have shown similar results, with rupture rates as high as 30% for women and mortality rates nearing 80% at 3 years. However, these studies are small and have important limitations, highlighting the need for more research in this area. Beyond the clinical relevance of this paper, though, I think it is worthy of discussion for a second reason, and that is its methodologic use of a competing risks model. Since this is what the primary analysis of the paper rests on, I think that it's worth taking a moment to understand what this type of model does. The reason the authors chose this type of model is due to the assumptions underlying a classic Kaplan-Meier analysis, which is something I'm sure that you've all familiar with seeing in the Journal of Vascular Surgery. Kaplan-Meier analysis assumes that patients who are censored remain at risk for the event of interest. However, this assumption is not true if the censoring event changes the risk of having the event of interest. For example, in this paper, a patient who dies of a heart attack is no longer at risk of AAA rupture. Therefore, using a Kaplan-Meier model can overestimate the incidence of the event of interest because of this assumption. Let me show you what this looks like visually. Shown here is an all-cause mortality curve from a paper by Dr. Fine, one of the leading experts in competing risk models. If we split the mortality events into cardiovascular and non-cardiovascular mortality, respectively, censoring for the opposite death event, and then use Kaplan-Meier analysis to model them, we get these lines shown in green and blue, respectively. However, shown in red is the sum of the green and blue lines. As you can clearly see, the sum of the two Kaplan-Meier estimated mortality curves is greater than the actual observed all-cause mortality because of the censoring assumptions. This causes an overestimation of the event rate when competing risks are present, highlighting the utility of using a competing risk modeling technique as used in this paper by Drs. Lancaster and Chang. So that introduction, I will stop sharing and hand it over to Aaron.
All right, good evening. My name is Aaron Barnes, and I am the chief resident here at Dartmouth-Hitchcock Medical Center in New Hampshire. Thank you for the opportunity to participate in this journal club this evening. I will be presenting an article entitled "The Natural History of Large Abdominal Aortic Aneurysms in Patients Without Timely Repair." This work was first authored by Dr. Elizabeth Lancaster, with Dr. Robert Chang as the senior author. I think it's fitting that Dartmouth is discussing this paper, as Dr. Chang is a graduate of the Dartmouth Vascular Fellowship. As has already been noted by Dr. Colombo, contemporary data on the natural history, and specifically the rupture risk for large AAAs, is lacking. The objective of this work was to examine the impact of AAA size on the incidence of rupture and mortality in a cohort of contemporary patients with large aneurysms. A multi-center retrospective cohort study was performed using the Aneurysm Surveillance Registry within the Northern California Kaiser Permanente system. The cohort was built using natural language processing software and text extraction to identify aneurysms 5 centimeters or greater in women, or 5.5 centimeters or greater in men, within imaging reports between 2003 and 2017. Patients who initially did not meet this size threshold but experienced aneurysm growth to meet size criteria were included. The primary outcome evaluated was aneurysm rupture. This included what the authors termed, quote, probable rupture, which was used and defined as timing and findings consistent with aortic rupture without a more likely cause of death. Secondary endpoints were overall mortality and reasons for delayed or no AAA repair. Sub-analysis and modeling included a competing risks model using cumulative incidence function to account for the competing events of death and aneurysm repair in determining the cumulative incidence of rupture. Figure 1, shown here, depicts the study population flow diagram. The mean age was 84 years, 71% were male, 78% were white, and 32% were current smokers. Of the 3,200 eligible patients, 44% had large AAAs at index imaging, and the remaining 56% progressed to large AAAs during the follow-up period, with a mean time to progression of approximately 4 years. Overall, 1,800 patients, or 58% of the cohort, underwent AAA repair within 1 year of the first large size revealed by imaging, with 332 patients, or approximately 10%, undergoing delayed repair, and just over 1,000 patients, or 32% of the cohort, having undergone no repair. The most common reasons for delayed repair were size assessment discrepancies between the surgeon and the radiologist, patient comorbidity per surgeon assessment, and patient preference. Among patients who never underwent AAA repair, the most common reasons for no repair included patient preference and patient comorbidity. In this cohort, women were significantly less likely to undergo timely repair, as defined as within 1 year, with a 1-year AAA repair rate of 66% in men, compared with a rate of 38% in women. Additionally, women were significantly more likely to never undergo repair than men, at 49% versus 25%. In this cohort, 216 patients, or 7%, experienced definite AAA rupture. The 3-year cumulative incidence of rupture was 3% for initial AAA size 5 to 5.4 centimeters, which included women only. 2% for 5.5 to 6 centimeters, 6% for 6.1 to 7 centimeters, and 18% for aneurysms greater than 7 centimeters in size. A total of 67 patients were defined as experiencing the probable rupture I described earlier. When the probable ruptures were included in the competing risks model, the 3-year cumulative incidence of rupture increased to 5% for AAAs with an initial size of 5 to 5.4 centimeters, 3% for 5.5 to 6 centimeters, 7% for 6.1 to 7 centimeters, and 19% for those greater than 7 centimeters. Sub-analysis was performed evaluating the cumulative incidence of rupture across sex and aneurysm size. As shown in the middle panel, this demonstrated that among patients with aneurysms 6.1 to 7 centimeters in diameter, women had a significantly higher cumulative incidence of rupture than men. Women with AAAs in this size threshold had a 3-year cumulative incidence of rupture of 13% compared with 5% in men, and this difference was statistically significant. An additional sub-analysis was performed across sex after excluding the 62 patients, which represented about 29% of all ruptures that experienced rupture at the time of their initial imaging study. As shown again in the middle panel, even after excluding those that experienced rupture at the time of their initial imaging study, a similar trend in rupture events with women experiencing overall higher rupture incidence than men in this specific size group remained. In addition to the limitations discussed by the authors, I think it's important to note that while this data demonstrates trends among women with large aneurysms, the sample size among women with large aneurysms in this analysis is still quite small. Additionally, the rates of rupture are lower than in prior published studies. It's unclear how much of this is attributable to the use of the competing risk model, as was nicely presented by Dr. Colombo, as opposed to the Kaplan-Meier modeling, or whether this could be attributed to advancements in medical therapy in general. In conclusion, this study adds important data to an area which is historically very difficult to collect data on. Their work demonstrated annual rupture rates for large aneurysms are lower than those reported elsewhere in the literature. The authors also highlight the lower rates of timely AAA repair among women when compared to men, and the increased risk of rupture in women compared with men with aneurysms in the 6 to 7 centimeter size range. Overall, the authors present very interesting findings with implications for the management of patients with AAAs, especially those who may be too comorbid or not ideal candidates for operative repair.
Thank you so much for the opportunity to moderate this evening. And please, if you have questions, type them in the chat. I have to also thank Dr. Lancaster and Dr. Chen for being present here for this wonderful manuscript, Dr. Colombo and Dr. Barnes' great presentation. I actually find it super fascinating that in your healthcare system, you find patients who do not undergo repair of their AAA. I can attest that in other areas of the country, having a small AAA is more dangerous than having a 7 centimeter AAA because it really undergoes repair in diverse practices with impunity. Now, I have 2 questions to start the conversation because your system is really geared towards taking care of patients within your system. Are all patients offered AAA screening? That's my first question. And the second question, the sex disparities are quite striking and in fact raises a lot more questions. And I'll be curious to see whether you're looking into these sex disparities because it's a great opportunity for a qualitative study. Thank you.
Thanks. Elizabeth, do you want to take a stab at those?
Yeah, absolutely. Thank you so much. Thank you all for being here and for the opportunity to talk about our paper. You know, within our healthcare system, Kaiser is a pretty aggressive system with regards to preventative care, and that involves screening. So I would say probably our screening rates are a little bit higher than the general population. And then definitely sort of the follow-up and referral rates are really excellent also because it's within this closed system. And then with regards to your second question, we also were very interested by the findings related to sex and, you know, risk of aneurysm rupture, the way that aneurysms are getting repaired, and then even that group of women The rupture rate, in that group of women with aneurysms between 5 and 5.4 centimeters was also, I think, really interesting because they ruptured at a higher rate than the total cohort did, between, with 5.5 and 6 centimeters. So I think there's definitely some interesting findings there. And we really want to be thoughtful about how we analyze them with regards to looking at disparities in care versus biologic differences between men and women. And I think that is sort of a important and nuanced analysis that we are excited to undertake.
I would quickly add that we do have a comprehensive AAA screening program. It kind of rolled out a little bit later in the study period than this particular manuscript, but it is now widespread and offered. We actually presented it at the SVS this past year, and so that manuscript should be coming anytime now. And the benefit of the integrated system and the electronic health record, which has actually been in place since 2004, allows us to look at these patients, who don't just, cross our paths because they had a procedure. So it gives us the opportunity to ask the questions about, well, what happens to the patients who don't get one? Because really that's the question, right? Like if we do or don't do a procedure, oftentimes we say no, or they say no, and we never see them again. We actually don't know what happens to them. And so I think this is an important part of, understanding the quote unquote natural history. I was a little surprised. I was very surprised by the results in the sense that I just in my head always thought that, if there was a 5% 1 year rupture risk, that made it 10% at 2 years. I don't know why I thought that, or if everyone else thinks that, but these results definitely do not support that kind of growth rate or rupture risk.
I think Dr. Belanconda had a question if she wants to go ahead.
I don't think we can hear you. You're not on mute and I can see your mouth moving, but for some reason, the microphone isn't working.
How about this?
Perfect.
Oh, wonderful. I was curious whether there was any consideration of aortic size index when looking at risk of rupture. As it's known, women have a lower baseline aortic size. So teasing out whether gender is a representative of baseline aortic size versus a true contributor to rupture itself would be very interesting.
Yeah, that's a great point. And we did sort of look into the literature on aortic size index, and we considered it as an analysis. Ultimately, we presented our data for this manuscript in this way because we felt like it was sort of an accessible way to present the data. But I think that will be a really important part of the analysis when we really try to dive into the gender differences in rupture. And we're also looking at growth of it. Aortic, we have some good natural history data on growth, and I think that will be a really important consideration also.
I think Dr. Forbes has a very, very, very good question if he wants to.
Oh, great. Thanks. Well, congratulations, Dr. Lancaster and Chang, for really a thought-provoking paper. As a specialty, we really don't have a lot of good natural history data. So this is a really important paper. And so I guess my question is kind of the fundamental, why do you think you saw a decreased rupture risk for large aneurysms? Do you think it was a problem with our initial understanding and the data sets and our analysis of it? Or is it maybe some change in pathophysiology, biology, or maybe how we risk factor modify and treat patients medically? Maybe we're doing something good. We're preventing ruptures because of the medical management. What do you think?
I think it's probably both. Looking back at, the main landmark papers as far as rupture risk in aortas, they all used Kaplan-Meier analyses, not this competing risks model. And so I think that absolutely contributes. I think probably medical management, smoking cessation, anti-lipids, antihypertensive, all of that also has to do with it. We sort of played with the idea of trying to do a multivariable model looking at, certain medication use, certain medication adherence, but we just felt like overall those statistics weren't sound because the overall rupture rates were so small that it sort of made us a little bit nervous to try to represent associations using the data that we had. So we can't say definitively with what we have, but I think that is along the lines of what we're thinking for why.
And Tom, I would say that, to be fair, the generalizability of this paper is really just in our region, mainly because of the demographics. For example, California has a way lower, smoking rate, active smoking rate than the rest of the nation, certainly more than other subregions. And then within Kaiser itself, the smoking rate's even lower still. So while this focuses on patients with aneurysms and they have high smoking rates, in general, the population has a lower kind of comorbidity rate. There's better kind of cardiovascular risk reduction, a lot of programs in place to cement that into the pathway. So given all of that, these are the data that we have.
Dr. Globitsky, would you like to place your question?
This was really a great paper and thought-provoking paper because in men, clearly the rupture rates are much lower than what we learned from previous studies, specifically from Dr. Lederle and the Adams study, that showed a much higher rupture risk rate in men. So my question was, did you look at the risk factors of rupture in the group that was operated compared to those who did not undergo repair? And maybe we operated or you operated those who were prone to rupture, and this group maybe had less risk factors.
So we did look at the differences between these two groups, patients that were repaired and patients that were not repaired. One of the big reasons that patients weren't repaired is other comorbidities. The surgeon deemed them to have too many comorbidities to undergo rupture. And so that was a factor in which the two groups were very, very different from each other. And I think we can sort of take that at face value, but again, it's like I said, it was hard to build a multivariable model to really look at risk factors in a formal way because of our numbers. We just felt a little bit uncomfortable with that. But I think absolutely that there are important differences between the groups that can be informative.
Is it possible that maybe they died before their aneurysm could rupture?
Absolutely, yeah. Yes, absolutely, which is an important factor, and why I'm thankful for the discussion that Dr. Colombo gave us on the competing risks model, because it is a really different way of looking at the data compared to how we've looked at it before, and you have to adjust your thinking a little bit with that.
Well, congratulations.
I think the question that we have to ask ourselves beyond these findings is, how do we incorporate that into what we know about operative risk and patient survival, and present kind of more comprehensive picture to these patients about whether or not they really should undergo repair for an aneurysm that could threaten their life, whereas in most cases it's something else that kills them. So that's kind of where we're headed next with our kind of research ideas.
So we are getting close to the end of the hour. Bobby, it would be terrible if we didn't allow Dr. Goodney to unmute and ask his question, considering he has a statistical, or it's actually not a statistical question, but he does want to know how you counsel these patients. And I'd love for him to ask it, since I know that you worked at Dartmouth.
Thanks very much, Dr. Humphreys, and congratulations, Dr. Lancaster. Wonderful job in elegant study design and unique data that really leveraged all the resources that the healthcare system at Kaiser brings to bear. And congratulations to Dr. Chang on a great project. So my question is simple. What happened to these patients when they did come to clinic? Do did you continue to follow them? Did they continue to have visits and surveillance, or did they just sort of say, you know, enough is enough, I've got enough healthcare troubles, I don't need another doctor visit? Because I often struggle as to when we should release someone who you know is probably never going to get an operation, but sometimes they kind of feel like an old friend at that point, and it can be hard to let go. So can you tell, did you look through the charts kind of to see what happened?
Yeah, I mean, I think we did go, you know, Elizabeth was about to probably say she, and did go through all those charts and did write down, you know, exactly how they, you know, did not come to repair. A lot of times it was the primary care provider kind of shutting the door before you could even open it into the clinic. And some were just, you know, a patient. And we do have those numbers of who actually went to see a vascular surgeon at all. And then, you know, to your question about, so there are many, many reasons, and we kind of catalog them all and we lump them all together because it's hard to parse out exactly what we could tell about that. The second point of, well, do you still follow them afterwards, or when or why? So we have in our registry a code that the nurses would use that if they no longer wanted, if they refused repair, but they wanted to have surveillance for whatever reason, they still stayed in their surveillance track and they continued to get that. Whether that might change someone's mind down the road, you know, who knows, you know, whether they still have a large aneurysm that they're sitting on or we're sitting on clinically. But then when they have absolutely refused repair and they don't want any more surveillance, they kind of fall out of the registry, documented and so forth.
Yeah, it's always sort of an interesting question about the cost utility of surveilling an aneurysm, you know, you're probably never going to fix, especially in a system like Kaiser, which is pretty cognizant of their costs. So great that you're beginning to sort of peel back the onion a little bit on that topic. So again, congratulations and nice work.
So very, very exciting time, and just really enjoyed having everybody here tonight. We are coming up on the top of the hour and being respectful of everybody's time, especially the East Coast people who have to go shovel snow or do something that I don't quite understand. I'm happy to. We had a conversation, Phil, before you came on about snow. So wonderful work. We're super excited to have everybody here to encourage discussion and to really generate a lot of great discussion about these topics and research that we're interested in. Don't forget that we'll be doing this again in February 9th. You'll see some reminders go out and promotion on the SVS website, as well as through email and to all the program directors. Thank you very much, everyone, and have a wonderful evening.
Thanks, Misty and Paul. Great job.
Thanks, Misty. Appreciate it. Stay safe.
Thank you, everybody.
Thanks all.
Thanks, Misty. Thanks, everyone.